We often get asked the question of, can we vary the drill kits for our specific setting or adjust the scenario and continue to run it or change it to make it more applicable to our setting? The answer is, of course, right? Our goal is to give you the tools to be testing this process. It's not a one size fits all. There's variations in how practices run, their policies, their personnel, everything. So the goal is really to give you the tools. Um, and you can take it as is if that works for you and your teams, or you can adjust it. Recently, we got asked a question or feedback of the fetal heart tone counts. We had them written in the drill as 6 seconds. This team usually was used to doing them as 5 seconds. So maybe that's an adaptation that they make in the future is they change them and do 5 second counts. Our goal is to empower you and your teams to be using these drill kits in whatever way is going to make the most sustainable change for you and your practices to be running these going forward.
One thing I'll add to this is that one of the requests that we have gotten a few times is like, can we get drill kits for emergencies that we resolve successfully in the community setting? Um, and that's one of the modifications that you can make to this if you want to. But I think that when you, especially in a community birth setting, like a birth center that's doing their quarterly drills, which is part of the accreditation standard. And so usually the whole team is all together, and to not use that opportunity to at least talk through and model out the actual transfer process seems to me like a missed opportunity. So I think even though, yes, we acknowledge that like with appropriate midwifery management and application of the tools that we have in community birth settings, we don't always transfer for every hemorrhage. We don't always transfer for every time of fetal heart rate dips. And there is room for clinical management and clinical judgment, but it's so important to drill and practice with as much fidelity as possible to the actual job of knowing who to call, where that phone number is, what to say when you activate the 911 protocol, what to expect, and how you're going to make sure doors are open and people know how to do wayfinding to where you actually are in the building. How are you going to give report and figure out who's doing what and how much care to deliver in the setting before you go. And so you can learn so much of that through a full transfer drill, but you can talk through or act out or initiate as much or as little of that as you want in the drill that you do in the partial transfer drill. So I would say I don't really recommend modifying the drill so that everything turns out great and you don't have to transfer. I would recommend using the debriefing time to remind everybody that you don't have to transfer every time this emergency happens, and what it would look like for the emergency to have happened and everyone to be stable and to feel comfortable with continuing on or with early discharge or whatever the standard is.
Yeah, that's a good point of clarity. Thank you. And I think one of the questions that we did include in that debriefing guide, because it varies so drastically among settings, is if you're transferring a mom, do you transfer the baby too, right? I think I've worked at birth centers that automatically we transfer the baby, and I've worked at other birth centers that the baby stayed until the baby had recovered and then the baby was reunited. So using that debriefing guide as a chance to run through those different scenarios of, okay, maybe we would have kept this patient longer because we have access to these additional interventions. And so maybe in our situation, we would have stayed longer, but using that debriefing time as a chance to really walk through those different cases that might be more specific to you.
Yeah, I agree with everything that you've both mentioned for this specific question. It's such a great question. And the other piece that I also wanted to highlight is that we acknowledge and know that community birth is happening in so many different types of settings. This program is not birth center centric, even though many drills may be worded in a way that looks like it can only be applied to the birth center setting. We have done a lot of diligence with our language, so home birth providers feel extremely included, even if the language of the drill scenario looks like so-and-so arrived in active labor to the birth center. You can easily turn that into like midwife arrived in the home, and just trying to make sure that the language and the setup is applicable across community settings.
Mm-hmm. Yeah, we're trying to do the adaptations for you when we can, or just use neutral language, but some of them, they do kind of, are envisioned in us in a birthing location, like a facility, a birth center facility, but that's also easily modified for the ones that are set up that way. And also we've also had questions about adapting them for hospitals, like community hospitals or critical access hospitals, and we think they're easily modifiable. We encourage people to try, and if it doesn't feel like it worked that well, then we're interested in hearing about it and hopefully continuing to develop the program so they can be used in a wide range of community settings.